I'd like to welcome everybody to the Department of Surgery Grand Rounds, and this is the inaugural Harriet Tubman Lecture on Health Diversity and Racial Disparities. Well, this is a very important event, not only for the department, for the medical school and university, because I think it's one of the first such academic events, and we're happy to share the room, the venue, and sponsorship with the School of Medicine. Thanks also to the Department of Pediatrics for sharing and allowing us to use their time and space. I think this is going to be of general interest and importance, and I think at the end of the hour, I think everyone will agree that it's been time well spent. In these sorts of events, everyone thanks people who may not deserve the thanks or praise, but we thank them anyway. But these people definitely do deserve our thanks, and that's Norma Tennant and Sharon Bartholomew, Rhonda Fike. They're the people who really worked hard to make this event come through. To them, and we owe our thanks, and that's very, very much so. If you came to the event last night, you know something about Dr. Frederick, but I'll repeat it because it deserves mention. Dr. Frederick is one of the rising leaders in America, period. There's going to come a time where you'll say that you heard Dr. Frederick speak at West Virginia University, because I'll say within a decade he'll probably be untouchable. He's professor of surgery and surgical oncology at the Department of Surgery at the Howard University School of Medicine. He's currently the interim president of Howard University. He was profiled recently in the New York Times article last week. If you haven't read it, please do. You'll appreciate the level of commitment that he has for his university, his cause, his vision. If you went to the lecture last night, you know something about the very creative ways that he's doing, that he's employing to address the problem of historically black universities and colleges, and assuring their survival in the next decades, and assuring that the desperate problems of access to not only to education and resources and health are addressed in a very creative and meaningful way. He has held positions of increasing importance, including going to medical school and undergraduate school at Howard University. He trained in surgery in their residency in surgery. He had a brief hiatus where he took a fellowship, 4-year fellowship at the MD Anderson University, but came back in short order to the Department of Surgery at Howard and quickly rose up to the ranks, including being the director of their cancer center, being their provost for health sciences, and this past year being appointed as their interim president of the entire university. He belongs to most of the important organizations in American surgery, including the Society of Black Academic Surgeons, the Society of University Surgeons, the Southern Surgical Association. It's only a matter of time before he completes the roster in the cursus honorum, as it were. He's testified before Congress on the topic of health disparities and surgical outcomes. He's had federal grants totaling in the 7 figures, very strong 7 figures, addressing this problem. At the end of the hour, again, I'll almost assure you that you'll be very impressed by this young man. I'm honored to call him my friend. Wayne, thanks a lot for coming.
Hi, good morning, and I'd first like to start by thanking Dr. Nakayama for having me here. I'll also flout the prudence that dictates that I probably shouldn't single anyone out for the great hospitality I've had here at West Virginia University, but I have to take the opportunity to thank Dr. Knight for having to drag me around. She's been not just patient, but very, very excellent hostess, so I certainly want to thank her and thank the Department of Surgery. This is a talk, I tell my residents and students that when you give a talk, if you ask a question in the title, you shouldn't end with a question, and unfortunately, I'll end with more questions than in my title, but hopefully, as we go through the talk, it'll stimulate some thought about what we do and why some of the outcomes we see are so disparate. I think when you look at the disparities in terms of the treatment, research, and the outcomes, it's quite a variety of reasons that are playing into what occurs. What I think is interesting is our own perspective of it and where we apply, some of our talents in terms of trying to discover it. So just to lay out the problem, we often say that there's a significant disparity in outcome, but what are the facts? And I think this paper really outlined this very, very well. Black patients were less likely to receive surgical resection for early stage lung cancer. And you can see the numbers there. 64% of blacks received the appropriate surgical resection for early stage lung cancer, while 78.5% of whites did. In terms of radiation after lumpectomy, and this is something that I certainly see in my patient population at Howard, 77.8% received breast radiation after lumpectomy as part of breast conservation, as opposed to 85.8% of whites. Adjuvant therapy for stage 3 colon cancer occurs in 52.1% of black patients and in 64.1% of white patients. So clearly some significant differences, and same thing with early stage prostate cancer therapy as well. In this particular paper, in this particular factoid coming from the American Cancer Society, they looked at among African Americans in terms of 5-year survivals for most cancer sites, and again, significant difference in outcome. Thank you. Differences in survival is believed to be due to barriers that limit access to timely and high-quality medical care. We hear that all the time. It seems like an easy explanation, but it is rarely ever tested. And you'll see some data that I think will question whether that's the case. And African Americans are more likely to be diagnosed at a later stage of disease. When we review studies that show that white patients receive more aggressive therapy than any other racial ethnic group for lung, prostate, colorectal cancer, even in cases where evidence for clinical benefit is far less definitive. And that may speak not just to access, but the ability, obviously, to pay. The review found that racial and ethnic minorities receive disparate care treatment, cancer treatment in several studies. And racial and ethnic minorities were found to have less frequently received appropriate surgical resection, as pointed out before, for lung and colorectal cancers. Again, confirming the same things that we saw in the other paper. Black women were had less definitive local regional treatment when you look at breast cancer, hormonal therapy, and chemotherapy. And Hispanic women were less likely to receive hormonal therapy than white women. And again, I mean, when you look at these things, one of the things that I have often seen as I go back and I look through some of the data, it starts, I think, a lot with clinical trials. The participation in clinical trials is extremely poor in terms of recruiting minority patients. And I think when you look at then the things that we do based on that, you have issues. We write tamoxifen for patients fairly consistently. ASCO once made a request of me to write a clinical guideline on tamoxifen. And one part of what they challenged me to write about was using tamoxifen in African American women. And the reality is that tamoxifen has never been studied in enough African American women to have a firm conclusion about its use. But we have extrapolated it and used it. It turns out that the P450, the cytochrome P450 system in African Americans may be different biologically, and therefore the metabolism of a lot of drugs may be significantly different. And when you think about the fact that African Americans are not participating in clinical trials, to subject them to some of those drugs based on these studies may not be the right thing. The other thing that we see is BRCA screening. Only 1/3 of black women aged 50 years or younger who meet national guidelines get tested for BRCA mutation. So even gathering the necessary information on what the incidence is problematic. And we know today that triple-negative breast cancer association with BRCA mutation is pretty significant. And it's obviously significantly underutilized and something that we have to get more information on so that we can make stronger clinical decisions. And I think more studies, as represented on this slide, are coming out to suggest that must happen in Black and Hispanic women. Now, let me shift gears a little bit because we talk about access, but I'm not sure we always understand fully what that means and what effect it has on insurance and what some of our own perceptions are of the people with and without insurance. So health insurance coverage in the U.S. in 2009, prior to the Affordable Care Act rollout, is really an employer-based system, which is one important thing to know. About 17% of the population was uninsured. And you can see Medicare and Medicaid covered a significant portion of the population, almost 30%. Most people assume that people who are uninsured because they don't work, especially when you look at an employer-based insurance system that dominates the U.S. healthcare. Well, that's not always the case. When you look at the family work status of those who are uninsured, one or more full-time workers in 61% of those families. So they actually are people who work, but they choose not to have insurance. And that's full-time workers. When you add full-time and part-time workers, you really end up with only 23% of the people who are uninsured not having some type of a job within the family. When you look at family income as well, in terms of looking at the poverty level, you can then begin to see some reasons why patients may not be purchasing insurance. And then as the Affordable Care Act has been rolled out, there has been a lot of discussion about age and who are the people who are signing up and who are the people we're trying to attract to sign up. And you can see a younger population remains uninsured. This looks at the distribution based on race, and you can see that white patients are more likely to have private employer individual insurance as opposed to Hispanic and Black patients. And you can see that that difference in terms of where the burdens are in our system in general. Now, does it matter whether or not you have insurance, just as an independent predictor of outcome? Well, when you look at the different types of cancers and you look at the ratio probability of diagnosis of late versus early stage cancer for uninsured and private insurance, you are twice as likely to have a colorectal cancer in a late stage and an early stage if you're uninsured. And in breast cancer, that goes all the way up to an odds ratio of about 2.9. So clearly, it does matter if you're insured or uninsured as to when you'll be diagnosed. And there's no getting around that in our system. Now, there's the chair of surgery at Howard, Dr. Cornwell, who's a trauma surgeon. I didn't include this data in here, but he has a very interesting study looking at the outcome of trauma patients, whether they're insured or uninsured. In the first 48 to 72 hours, the patients do just as well, because you don't get to pick those patients. But within that first 48 to 72 hours, we all become aware of whether or not those patients are insured or uninsured, and what do you think happens to their survival after 72 hours? The insured patients do better than the uninsured patients. Is that because we are exhibiting some type of bias in terms of what we're willing to do for those patients or not, is one of the questions. Now, some people may argue, well, the insured patient is coming in healthier. So prior to their car accident, their blood glucose was good, their blood pressure was good, they took their meds, and therefore they were a good trauma patient for whatever that may mean. But when you control for those factors, the outcomes are still worse after 72 hours in the uninsured patient. So it does predict some opportunity there for us to probably change our system. And then, does it result in death? It's one thing whether or not you are likely to be diagnosed later, but does that result in a poor outcome? And you can see here again, it absolutely does result in a poor outcome in some of the major cancers that we treat. Now, our public community hospital system, I obviously talk a lot at major academic medical centers like yours, but most of our medicine really probably is given out in the community at the end of the day. And our public community hospital system is certainly under pressure. And those numbers are continuing to decline in terms of the number of public community hospitals that are available to the public. So where people have to travel for access to care may be making a difference as well. I like to put this slide up because this was a slide that the White House used before the Affordable Care Act rollout. It was well intended, as you would imagine, and it's, the intent here, as the discussion took place, was trying to explain what the Affordable Care Act would do. As you can imagine, this is a very complicated issue. And one of the things, unfortunately, that our media does is that it does not give, I think, the appropriate respect to the complexity of this issue. But we as physicians, I think we must do that. This is a very complicated issue. Trying to provide health insurance for this many people who live in so many different states, there's so many different laws, there's so much difference in terms of what we have in our ability to provide care, that it is very, very complicated to try to get this. So whether you're Democrat, Republican, Independent, you like the Affordable Care Act or you don't, the fact of the matter is providing health care to so many people is a very complicated issue. And how we do it, the impact it has, is one that we have to respect. Now, so far, and this is a fairly up-to-date slide, in terms of the discussions of how many people have been insured, how many people under the age of 26 have been insured. All of these are major factors, and I think as we track this, we really will get a better sense of whether or not this law will work and the effect it will have. And I certainly don't have an opinion yet. So as I became interested in the disparities of outcome, one of the things that very early on I started to realize is that we rarely discuss biological difference. Because of our racial history in this country, there's a little bit of an apprehension to suggest that we are different. I'm not sure that that helps us in terms of looking at what happens in terms of patient outcomes. As well as race and ethnicity are often melded together, and I'm not sure that that's correct as well. I grew up in Trinidad. I left Trinidad when I was 16. I'm a US citizen now. If I stand on the corner of the street and somebody drives by and hits me and I'm unconscious and I come to the ER, the intern who sees me will tell his or her attending that they're taking care of, hopefully they'll say, Dr. Nakayama, a young African-American male is how they would describe me, not a middle-aged African-American male, but I'll take that. But that's what they will describe me as, right? I'll immediately be described as an African-American male. But let's examine that. Am I truly an African-American male by your definition? Dr. LaSalle Lafall, who's my mentor, grew up in Texas, went to school in Florida. He was introduced in 1995 as the president-elect of the American College of Surgeons, as the first African-American president of the American College of Surgeons. And he often tells me that he wasn't, because there was a gentleman who was born in South Africa, a white gentleman, who was the president of the American College of Surgeons. Is he an African-American president of the American College of Surgeons? He's white, but he was from Africa. Is he an African-American president of the college? We make a lot of general judgments or in making certain statements that we're not sure about. So when students round with me and they say the patient is a 20-year-old African-American male in a hospital where 99% of the patients are African-American, I often ask them, is it important for me to know that the patient is African-American? What difference does it make in terms of when I go into the room or what you present to me? What difference is it going to make in terms of my treatment of the patient? Well, I did my fellowship at MD Anderson, and sure enough, I got a call one day to come to the recovery room because there was a blue-eyed Caucasian male, 44 years old, being treated for a melanoma who was in sickle cell crisis. I have sickle cell myself, and my attending knew that, and so they called me. The patient wasn't on my service, and as I was walking over the bridge to get to the patient, I started thinking to myself, this is unbelievable. I'm going to go see a patient with sickle cell, that everything that I've ever been taught about sickle cell was that this occurs in African Americans or people of an African diaspora? Well, the Mediterranean has some African diaspora in it, right? The Mediterranean, we don't appreciate that. And sure enough, he was from southern Italy, blue-eyed, Caucasian male who had sickle thalassemia, right? Now, just imagine the assumption, had they not mentioned to me that he was Caucasian and blue-eyed, I would have gone into the room and said, oh, I'm sorry, wrong room, left the room, right? So how much of it influences what we think when we interact with those patients? And that's important. So I did this study in conjunction with a friend of mine, a colleague of mine, Tim Paulick, who is at Johns Hopkins. We thought we would look at an operation that we both learned to do in the same place. We felt that we did it the same way, and therefore we felt that outcomes would be similar. But we thought we would look at it across the spectrum. So we used a national inpatient sample to look at hepatectomy outcomes. Major hepatectomy has generally become safer in the last several decades, especially in specialized hands. And racial disparities in surgical mortality have been documented for several other surgical procedures. So we wanted to determine whether in-hospital mortality rates after major hepatectomy vary between racial groups and to identify potential reasons for such disparities. So we looked at a nationwide inpatient sample. These were some of the criteria the patients had to have. We excluded trauma. And this was the result. These are the results in terms of the primary diagnosis. Most of the patients, as you would imagine, had metastasis. Hepatobiliary cancer was second on the list. In terms of results, 59% of the patients in our sample were white patients, 5.8% were black, 6.5% Asian. We looked at the mortality by race. And this is the first thing that jumped out at us. The mortality in black patients was 10.6%. Think of how safe it is to do a hepatectomy today. And in a national inpatient sample between 1998 and 2005, the in-hospital mortality rate for black patients having a hepatectomy in this country was 10.6%. Just imagine if it was 10.6% across the board, what we would be doing to liver surgeons in this country, right? We would assume there was a crisis. And this is an operation that in most of our surgical departments, we'd probably stop people from doing. There'd be a moratorium on this if that mortality was the same for everyone across the board. We looked at the socioeconomic breakdown of the patients. The black patients were actually younger, right? Another assumption we make, right? Most people see me. It was kind of funny. I was on the plane coming over here, Dr. Nakayama, and the flight attendant was giving out, some beverages, and she looked at me and said, "Oh, you're going to Morgantown?" I said, "Yeah." And she said, "You go to school there?" I said, I wish. And then she said, and so she kind of looked at me like, "Oh, hopefully one day," and walked away. But the only thing she didn't say is, the mountaineers are better than most. So, but we make a lot of assumptions. So most people see me make an assumption when I walk into a place about, he's one of the students. That's the most common thing that I hear. But I tell people, if I put on a hoodie and jeans on a weekend and I stand on a street corner, I tell my same medical students who look like me, if 100 of you drove by that street corner, how many of you, if I gave you 10 things to assume that I did, how many of you would guess these 3 things? That I'm the father, a married father of 2, I'm the president of a university and a surgeon, and then I give you 7 other things. How many of them would pick all 3 of those things? Right? The same people who I teach who look just like me. So we have those inherent biases. So we assume that the younger patient may do better. And as you can see, the black patients were younger. They certainly didn't do better. The female gender in a lot of these studies portends a better outcome. We're not always sure why. Dr. Cornwell tells an amazing story of a patient who was shot at Hopkins. The bullet penetrated both testicles. They tested his testosterone level. He had multiple other injuries in his abdomen that he survived. Amazing injuries, iliac, etc. But when they tested his testosterone levels, they were extremely low. And they theorized that that actually helped him. Now, you can't do a control study to prove that, right, in trauma patients, but a fascinating thought process about the effect of hormonal influence on outcome. Does that matter? And may it matter as we go forward? Would we use estrogen in a trauma setting to probably get some cardioprotective effects? Something to think about. Female patients, as I said, they did better. Elective operations, not a big difference there. But then when you look at whether they had Medicaid or they were poor, significant differences. The low volume centers, which is something we hear about a lot, the trend clearly, as you can see here, was in a direction where the black patients were being treated at low volume centers. The other disclosure I have to put is you can see the N for the number of black patients as well. Cirrhosis, they were more likely to have cirrhosis, hepatitis as well. When you look at the multivariate analysis of mortality using whites as the standard, black patients were twice as likely to die in the hospital. Just a significant difference. When we look at the important clinical factors in blacks versus white patients, clearly the cirrhosis and hepatitis stood out. We looked at low volume versus high volume, and as I said, the p-value did not rise there, but again, I think something for us to always be thinking about in terms of the quality of care someone might be getting. We looked at whether the patient's poor, rich, or private insurance, and you can see again there what the p-values were and the odds ratio. So blacks have a higher adjusted risk of in-hospital mortality than white patients after major hepatectomy, even when we try to control for some of the factors. This disparity persists after adjustment for several clinical and hospital level factors. And the disparity may be partially explained by socioeconomic factors, but I don't think it's fully explained by that. I show this picture because this woman was a grandmother when she came into my office. She was in an Eddie Bauer coat and pushing her grandchild in a stroller. In other words, the picture of normal in America that you would think of. Got into my office, took off her clothes, got into a gown, and this is what I saw when I examined her. I was totally shocked. I positioned myself in between the patient and her grandchild just so her grandchild would not see this. And the grandchild had to be probably just 18 months. And I just could not imagine that she was taking care of this young child while walking around with this lesion that she had been walking around with for a while. We had a robust hour-and-a-half discussion. The rest of my patients were upset that morning because I stayed in that room to convince this woman about what she needed to do to take care of herself, using her grandchild as my number one reason. This is what happened the next time I saw her. That lesion on her breast became a fungating mass. I did 4 years of surgical oncology at MD Anderson Cancer Center, and I never saw a lesion like this. In my first 18 months when I came back to Howard University, I took care of 22 patients with lesions like this in Washington, D.C., our nation's capital, where you cannot argue to me that access to care is the cause of this. Access to care is not the cause of this. You've got Georgetown, GW, Howard, you've got Sibley, now owned by Johns Hopkins, you have Washington Hospital Center, all within a small area, very small city. Access to care is not the issue, and the majority of patients are insured. Contrast that with this patient who came to see me, a young Caucasian female who had a sub-centimeter cancer in her right breast and insisted on a mastectomy with reconstruction, and this was her outcome. Psychologically, by the time we finished tattooing her, etc., she had a perfect outcome in terms of aesthetics. She was extremely pleased, etc. And you contrast that with the image that I showed you before. And as you would imagine, by the time I did do a radical mastectomy on the prior patient. She probably lived, I think, about 7 months longer, died from widely metastatic disease. So that brings me to the next thing. African American women are less likely to get breast cancer, but they are far more likely to get the most aggressive type of breast cancer, which is triple negative breast cancer. So I did a study when I first got back to Howard to look at the different subgroups of breast cancer in the African American women patients we were seeing to see if there was a difference in outcome. And so I'll show you some data from this study. And we looked at several things: overall survival, we looked at distant metastasis-free survival, local regional recurrence, several aspects of this. And so this is what we found. The basal cell-like is the type, the subtype, that's the triple negative. And if you look at the incident, positive node status significantly higher in that patient group. When you look at tumor size, the tumor sizes were more likely to be greater than 2 centimeters as well. So clearly there were things that suggested that these patients would have difficulty. Now look at this. Less than 35 years old, 20% of the patients with the basal cell-like were less than 35 years old. Very, very young. Our screening guidelines would not even bring these patients to our attention in a conventional manner. Not only would it not bring those patients to us in a conventional manner, but a lot of times these patients don't know their family history. So the other triggers for why we would screen these patients aren't there as well. And I think that often is problematic. We look at how these patients were treated, and the vast majority were having mastectomies. Now, 35.2% were treated with breast conservation. However, 16.9% were patients treated with breast conserving surgery who did not go on to have some type of treatment. And that obviously is problematic. The basal cell-like patients were more likely to have adjuvant chemotherapy. And that's fairly consistent, I think, with the literature. And so we did some analysis in terms of what their survival would look like. And the distant metastasis-free survival, as you can see on the hazard ratio for those patients, despite the fact that they may have received a mastectomy, was not very good. Same thing with respect to the larger tumor size as well, which they had. And then using less than 35 as the standard group, you can see that in terms of the mortality in the group from 36 to 50 years, young women very, very likely to die of this disease. Same thing when we did a Cox proportional hazards using the luminal A subtype as a standard. Again, you can see 2 to 3 times more likely to have a poor outcome in most circumstances for these patients. And then the local regional recurrence was also very high. This is what the survival curves look like. You can see that the basal cell-like patients have a significantly higher mortality throughout. And so we saw no substantial difference in the overall survival between breast conservation and mastectomy. The molecular breast cancer subtypes treated with breast conservation therapy were more likely to have a shorter distant metastasis-free survival. The basal cell-like subtype was an independent predictor of a shorter distant metastasis-free survival. No significant difference in local regional recurrence between breast conservation and mastectomy. And then the basal cell-like, again, showed a trend towards independent predictor status for local regional recurrence. So clearly, the basal cell-like subtype was associated with a worse prognosis, a higher incidence of distant metastasis, and maybe more prone to local recurrence when managed with breast conserving therapy. This, I think, is a major issue when you look at African American women and breast cancer. This mortality is high, and there is something that we need to ask ourselves about this disease in particular. Is it a different biology? I think it's a fair question for us to put on the table. And so we started getting interested in looking at the molecular biology and the subtypes and what some of the outcomes would look like. The other interesting thing that I found, I got a call one day from a woman in Britain who had looked at black British patients and had the same finding of triple-negative breast cancer. So the other question we had was, is there something happening with the African diaspora in particular? And Lisa Newman at Michigan does some studies on patients in Ghana, where again the incidence of triple negative is extremely high as well. So clearly there's some kind of connection here that is clearly showing that there's a higher incidence of triple negative breast cancer. So we wanted to see, are there molecular biomarkers that we can target that would probably respond to this? So are there druggable targets? Are there targets for which we know currently there are some types of treatments that we can then apply to these patients? So we used tumor microarrays to do the study, and we wanted to look at FASN, CD105, and beta-catenin in particular. Two pathologists independently looked at the slides after we did immunohistochemistry staining to decide whether they were positive, negative, and to rate them. And then we did some statistical analysis around the things that we would usually test. And this is some of the data on the patients. Most of the patients in this particular study were older, as in greater than 50. Estrogen receptor positive was significant at 57.4%, you can see. But we did have triple negative incidence of a significant amount as well. And you can see the staging groups, again, all of what you would expect in a particular population. And this is what some of the outcomes in terms of survival, but I'll show these independently for each of these. As you look at FASN in particular, we looked at whether FASN was positive or negative in the ER positive patients versus ER negative and so on. And you can see the p-values there in terms of that incidence. So clearly the FASN was positive when ER, the estrogen receptor was negative in these tumors, and we felt that there was a strong association. You see that represented here. Again, when FASN is positive, the tumors were more likely to be ER negative and PR negative and triple negative when the FASN was positive. So clearly a strong association. Now, did that affect survival? And again, same thing with the green line being the FASN positive patients. Those patients had a poor survival. So our conclusions here were that this expression correlated with ER negativity, PR negativity, and triple negative status. And it may correlate with a specific triple negative subtype as well. FASN, however, is a druggable target. There is a natural compound that exists, and so one of the things we're very interested in is looking at this as a potential treatment. We looked at endoglin, CD105. It's a membrane glycoprotein and functions as a component of the TGF beta receptor complex. And we looked to see, what would happen again with breast cancer patients. And again, if you look at this with the HER2/neu positive, when CD105 was positive in the triple negative, you can see that most of them were actually CD105 negative. The HER2 positivity, though, CD105 was positive. And then when we looked at the outcome, again, you see a correlation. So the expression correlated with a HER2 positive subtype in particular, which we know from a prognostic point of view does have a poor prognosis, but we do have a drug to treat that, obviously in Herceptin, but CD105, again, may be an opportunity here to treat with an anti-monoclonal antibody. We looked at beta-catenin as well, and again, you can see the results on this as well. The association with the BRCA mutation and the changes that take place make this, I think, an interesting and important thing to look at. And as we look at transmethylation in ER tumors, I put the slide up only to demonstrate that the number of targets that I think would be available to us if we can find the right one that has the correlation are enormous. Trying to tie that then to the biology and the incidence, if we can get these patients tested for BRCA mutations, may give us some opportunity to look at. So in terms of future studies that we're looking at, looking for additional biomarkers is important, I think, for us to try to find the appropriate targets. We talk a lot about personalized medicine today, and clearly when we look at some of these tumors, I think this is the direction that we certainly must go in. And I think it's important. And why is it important? I really think it would inform us about some prognosis. There's another interesting fact in terms of when you look at the drug metformin, which holds promise for the treatment of triple-negative breast cancer. There have been some early studies looking at using metformin, and also the link of patients that have insulin resistance and diabetes and their poor breast cancer outcome. Again, in these populations, those things tend to run similarly in the patient population, and again, I think that there may be opportunities there for us to have some targeted treatment. The one thing that is a concern, it has now been demonstrated that triple-negative breast cancer is associated with the BRCA mutation. African-American women and the incidence of that, as I described earlier, is still an unknown. And we have to get studies there. And as I said, I would ask more questions at the end of my talk than I would have answers for. But I think these are intriguing questions. Is that high mortality rate due to just the triple-negative prevalence? Or is some of it the treatments that we've been using for them? I think it's an interesting question. The BRCA mutation issue obviously is one that we must have answered in the near future. And then the other thing is, can we predict who is at high risk and mitigate that risk? I think that's going to be an extremely important discussion as well. And then ultimately, can we decrease the mortality in ethnically diverse populations? I pose that question because the other step of this is treatment, right? When you have patients who have other factors that are influencing their healthcare outcomes, how are we going to manage those social determinants of care, of health? And can we do that successfully? And I'm not sure that I have the answer for that either. So we have to look at these things more closely. Some of the studies that Dr. Newman is doing in African patients, I think, is also very interesting as well. I have to acknowledge the folks at Howard University who participated in these studies. Dr. Nab is the lead pathologist who participated in this. We had a couple of grants that supported this. Dr. Louis Rick Santi is now at Hampton University, but she was a postdoc on my research team and did quite a bit of work on this. So thanks for your attention, and I'll take any questions.
Thank you very much, Dr. Frederick. Any questions? We have plenty of time.
So Wayne, again, thank you so much for coming and visiting. You know, I think that flight attendant may have been smarter than you gave her credit. We are searching for a university president. And one of the fits is you serve in an institution very similar to ours, because both of our institutions are looking at populations that have got huge disparities. We share that. And I'm thinking in terms of the cartoon that you showed yesterday that talked about equality and justice. And I'm thinking about yesterday's presentation was all about nurture, and today's presentation is all about nature, essentially. So as a university president, with a fixed amount of resources to allocate and a desire to do something about egregious disparities, do you spend your money on nature or nurture?
You know, I think that's a good question, and I'll have to use my my experience probably parenting. I have a 9 and 7-year-old, a boy and a girl, so I have my little experiment going on in my household about the allocation of that. And you know, I really think that when we talk about allocating resources, between the two, I don't think it's an absolute decision of one versus the other. I just think we have to find the right aliquots for each one, and we have to pay attention to how we apply it. We spend a lot of time talking about, for instance, the amount of money we spend on end-of-life care. That becomes a debate a lot, but we rarely get into the discussion about how much we spend on some of this disparate care. What does it take to treat somebody with a late-stage cancer, and what would we save if we didn't? We're still spending, we probably will spend the same money, but it would be on spending it on nature, but it probably would be doing it earlier on in the cycle. So that's one. Our future absolutely are our younger generations in terms of our student population. We have to spend money on nurturing them. I think we have become disillusioned. We often talk about that next generation in a very dismissive fashion, right? They didn't walk to school 3 miles without shoes on, a snowy day like we did, and therefore they don't understand. And I'm just not sure that's the case. As I mentioned yesterday, I have students who next month for spring break will go to 8 cities in this country and Haiti. 350 of them, 1,000 of them applied to go to alternative spring break, not to Daytona Beach. They're going to go into inner cities and help kids. These are students who are 18 and 19 who are coming to Howard, Pell Grant eligible, with very little financial resources, who could probably do very well if they spend their spring break working somewhere and getting some extra cash. But they will go and give service. And I really think that we discredit that generation. And I think if we spend some more time giving them a little more credit, they do things a little differently than we do. I agree. But I don't think that's a bad thing. I think we have to contemporize their experience. So I really think it's just the amount that you want to pour into the mix here, and we have to pay attention to both nurture and nature.
That's right. Hi. My question was whether you have any insights into what it would take to improve African American enrollment in clinical trials on a larger scale. Your studies were really interesting, but it seems like we just need more of those, right? So
Sure.
how do we overcome that 8% enrollment?
Right. So hopefully this won't make it to the New York Times, what I'm about to say, because I have a very different perspective about this. I think we have to change the rules about enrollment. Because we are concerned about safety, we have developed a very rigid clinical trial system, which I'm not here to beat against. Let me just be clear to anyone. I don't want anybody blocking me from leaving the room because they think I'm trying to subject patients to torture. We have to be safe, but I think we've swung the pendulum to a point where we've become inflexible. And when you have people who have to make decisions about childcare, about working, etc., enrolling in a clinical trial becomes a hardship. And we have to create a system that builds in more flexibility. And let me be very clear about what I mean by that. I think if we design clinical trials and the government decides that they will fund these clinical trials only if we support a certain subset of the patients must have a certain profile in terms of where you administer that care. So MD Anderson is a classic example. Huge place in Houston, Texas, but you cannot replicate what happens in those pink buildings. You just cannot. It's incredible, the infrastructure that's there. However, if 10% of all the clinical trials they do had to take place in the community, you would get a very different patient mix and outcome. And if you force them to put resources in the community centers around so that those patients can get treated closer to home, they can get better access around their work schedules, their daycare, etc., you would get a very different population. Now, some people may say, well, that's a whole lot of resources. I don't think it is, because if you look at the population who is treated at MD Anderson on clinical trials, it's about 10% of them come from outside of the state. So they're expending resources anyway on a different patient population, right? We're just expending it on people who can catch a plane to fly to Texas. And my argument is you have enough of those patients within Texas. Why don't you spend the same resources on that? This is an example. And I think if we do that, we would have better. The other reason why I think it's important is because some of these differences are biological, I believe. And I think that if we get to understand some of those, it may inform us about the other, aspects of the population as well. And I think that there would be. So my idea would be to relax some of the standards in terms of what we do for enrolling patients. Not everybody can move to Houston to participate in a clinical trial.
So then, do you think the Corey funding goes far enough to start pushing toward the patient-centered research to consider, really truly kind of like you're describing the community things, or is anybody advocating for similar to pediatric populations where drug companies got the extension of the CAT, that do we need those kind of incentives for things for other groups?
Yeah, unfortunately, the bottom line is always finances, right? If you think about it, the people who get the funding would be the best advocate. So if I'm the PI with a clinical trial and I advocated for having that particular population, we would get better. We'd probably get some of those better things. But that's why, as well, I think we have to have better representation in NIH and NCI at the time that people are designing these trials. Unfortunately, the discussion often comes up after we start enrolling the patients and we recognize that we're not getting what we need. It really happens on the front end of when we design. We have to get more advocates in the room when the trials are being designed to begin with.
Anna, you have a question?
Well, actually, thank you very much. I had one comment, and then I guess maybe some insight, although it's not one of those crystal balls, because if you probably had the answer to this question like last night, you wouldn't be sitting here talking to us because I think it's the big issue. We recognize in West Virginia, and everybody sort of talks about us and access to care as being a significant issue, and it's a different access to care issue than, let's say, in the inner cities, and it's mostly financial, but it's also sort of isolation geographically. So one of the things that we have started embarking upon is sort of developing a clinical trials network, which actually allows physicians in these remote hospitals and sort of these community-based, where most of our cancer care is actually happening, to be able to enroll patients on clinical trial as part of a greater statewide network so that it reduces their cost burden there. So that's sort of the development and how we're trying to address that. I think one of the comments you made earlier is very important. So there are 13 counties in West Virginia where stage per stage at presentation of breast cancer, the outcomes are worse. So it has nothing to do with what stage they present, it's what their overall survival is. So when we talk about access to care, we always think about screening, we always think about those kinds of things, but the reality is, like you talked last night, if you take a woman and say, okay, you've had adequate breast cancer local care and now your systemic care, you have to choose between buying your Arimidex, which makes you feel horrible, or you buy milk for your family, it's almost a no-brainer. And so sometimes, and I welcome your comments, I wonder whether or not some of this access to care isn't in the screening, it's in the adjuvant setting, because that's equally as important, access to care.
Yeah, good questions. Let me make a comment about your first one. When I got to University of Connecticut Health Center as a young attending, they would drive me around the state. So I hope no one in here is from Connecticut, because I might mess up the city. Somebody is, so forgive me if UConn Health Center is in a town called Farmington, and then there's a place called Torrington, which is a little further up. The clinical trial, so one of the Fridays they took me there to have lunch with the medical oncologist there, etc. And I made the trip. Very nice folks. They pulled out their clinical trial slate, and I was blown away. They had more clinical trials in their 6-person group than we had at the health center, at the UConn Health Center. I went back, I was like totally floored. I mean, they had tripled the number of clinical trials ongoing. And so to your point, I think those networks are extremely important. And if we could do more of that, I think we would help. And to your second point, in terms of access, I think you make a very, very good point. The young man who picked me up at the airport, he had the schedule of my talk, and he said, that looks like a very interesting talk. He looks like he's about a 35-year-old Caucasian male, and he said, when you talk about unconscious bias, what exactly are you talking about? And so I gave him a little 4 to 5 different points in about 30 seconds. And then he tells me the story that he is a cardiac patient who had a valve issue. He has seen 4 different cardiologists, and all 4 told him something different. And so so he was making the point that there is unconscious bias as well, because he looked like a young, healthy person, and so everybody he saw progressively prescribed something more aggressive. It went from somebody telling him he needed valve replacement to he needed a heart transplant. And then the last person told him what he wanted to hear, which was he needed a pacemaker. So he said, that sounds fine, and he has a pacemaker, has had it now for 17 years. Right? So is there bias in terms of what we prescribe for people? And as I demonstrated last night in the Hopkins study, the medical students, although they have an implicit bias about race, they often don't have an explicit bias about what types of treatment they prescribe. But something happens in our medical schools and our training that changes that perspective. Right? If we see one of our colleagues' wives as an example, think about the amount of information you give that person in terms of data. And then when you go and see the next patient who has the exact same diagnosis, think of the difference, and that's the nature of that conversation. We probably prescribe for each other the kitchen sink, and then we go to the next room and all of a sudden we get so pragmatic. Or you don't need all of that, you just need this. But your colleague comes to see you and all of a sudden they're getting I can do a tri-segmentectomy, I'll follow that up with a Whipple, and then we give you chemo, and that's right, you got stage 4 metastatic pancreatic cancer. And here I'm having a discussion with you about resecting your liver, resecting your pancreas, and then we can give you this new drug, and it's impractical. So I absolutely agree with you. I think some of that access we bias because we go into the room with a certain thought process about who that patient is, what that patient should get, and we have to get away from that. And we have to, but it's difficult because it's an emotional thing. Although we think we are so much in control, I think on any given day, if you see 3 patients that look alike and you think about what the discussion you had with them, it's 3 different discussions, you know. Even from a language point of view, you walk into the room and that patient speaks Spanish, all of a sudden your voice goes up louder and louder, like that's going to make the patient understand, right? That's an implicit bias. Because a person speaks a foreign language, all of a sudden you think if you shout, the patient will understand. But we do it all the time. Yes, you have stage 3 breast cancer. The patient is like, okay, I still don't understand you. You can speak as loud as you want. Right? So all of those things are things that we don't think about, but they do influence. And because we don't want to have a long conversation because we don't speak the person's language, that becomes a truncated description of the treatments you need. So I absolutely agree with you. But I think we have to fix our curriculum to address that so it doesn't happen as often.
We have some mementos, and I see Jen Knight creeping up. I think we have to have special thanks to Jen. Jen is going to be our point person for this symposium in the future, and we hope to expand. And I look to Jen for her leadership, and I thank Jen once again for leading this outstanding inaugural lecture. But we have some things for you. First is something that you can't take back with you, but it's I just want you to admire the plaque that's going to be hanging in the department suite with your name front and center, #1, the pole position, as we say back in the South. For the Harriet Tubman Professor celebrating diversity in medicine, distinguished speakers. And Wayne Frederick, his name is going to be on that. It's going to be in our offices. So Wayne.
Thank you. Appreciate it. Thank you very much.
And some things that are more tangible, and thank you once again for being our guest. We'll turn the room over, and in about 10 minutes we'll have case presentations by the residents, and Dr. Frederick will be discussing them. Thank you very much for coming.
All right, thank you.